I want to welcome everyone to the Live Well Kalkaska Substance Free Coalition's Coffee with the Coalition Forum. This is an open and informal discussion about substance use disorders, related topics and concerns within the Kalkaska community and Northern Michigan. I'd like everybody, except for our guests, to introduce yourselves. I'm Suzanne Prentice. I'm the coordinator of the Kalkaska Substance Free Coalition and prevention specialist for Kalkaska County through Catholic Human Services Up North Prevention. John?
John Supernaw. Am a peer recovery coach with Catholic Human Services, along with doing, I kind of named it myself, but I'm also kind of the community outreach point person for our office too. I do various things out in the community, like attend the coalition meetings in Kalkaska and Antrim County and Grand Traverse, and have a number of resource tables around Grand Traverse during the week, among other things, but that's basically the gist of it.
All right, thanks. Belinda?
Hi, my name is Belinda. I'm a prevention specialist with Kalkaska Live Well in Kalkaska County.
Thanks. Linda?
Hi, my name is Linda Solom, and I'm a certified substance use disorder prevention specialist with Up North Prevention, an initiative of Catholic Human Services, advancing substance misuse prevention efforts in northern Lower Michigan. And I'm also part of the Grand Traverse County Drug-Free Coalition and a board member of the Coalition to Combat Human Trafficking.
Thanks, Linda. Jeannie?
Hi, I'm Jenny Groover, and I am a project associate with the Northern Michigan Opioid Response Consortium, also known as NMRE, and I've been with NMRE for about a year and a half now.
All right, thanks. And I am going to welcome Branislava Arsenov. She's Clinical Services Director of Northern Michigan Regional Entity. She's going to speak about their services and the process for individuals seeking help and recovery from substance use through NMRE. Thanks for being here. Go ahead and take it away.
Thank you for inviting me. I'm going to try to share screen and let's see how that goes. Just to make sure that I'm not going to share something with you that probably shouldn't. I'm just going to close a couple things here. Oh, looks fine. All right. I have permissions to share, right?
Yes.
And are you able to see my presentation?
Yes.
It doesn't show that you can. Okay. That is interesting. Can you see it from the present? I have to change that. This is not working. On my side, it's not working. So I'm just going to do it a little bit differently, if that's okay.
Yeah, that's fine.
It was just not showing the way I wanted to show.
Yeah. It showed right on this end.
Really?
Okay.
Okay. I'm not very good with Zoom. That's what it is. It's me. It's the operator. So you can see it now as presentation, correct?
Yes.
Yeah.
Okay. All right. Now we start. So again, I'm B. I go by B for those obvious reasons. You just said my name, so it's a mouthful. I'm Clinical Services Director here with NMRE, and we're going to talk about some of the access and services that we provide and some other things that NMRE is also able to fund throughout the region. So anytime you have a question, just ask. You can unmute yourself and just say, hey, can you say more about that? There are some acronyms I've used and some things that I made a little bit shorter. Ask me what they might be if you don't know specifically what it is. Oops. Okay, there we go. So as most of you know, NMRE is a PIHP, or prepaid inpatient health plan, which is fairly robust as well, for 21 counties in Northern Lower. So what does that mean? That means that we provide funding for behavioral health services in the region. That includes 5 CMHSPs, or CMHs, in our 21 counties, and it also is covering all the SUD services that are funded through us and paneled, and prevention services, health homes, and so on. So there's a lot of different things that we do as PIHP, and we're going to cover a small portion here today. So quite often, next question is like, well, which 21 counties do you cover? And sometimes it's very hard to explain that. And I was like, it cuts off there, like Manistee, Wexford, and Iosco. So this is where the line is. These are our counties. And this is our little island up here as well. So we shouldn't be forgetting about that. So this is our area. This is what we cover with all sorts of services. So we can start with, your kind of question was, can you talk about how people access services? What is it that they need to do? When is it that they need to call? So most of the services, higher level of care, and we can talk about what that is, with NMRE start through access to care. And our access has a couple of care managers and care coordinators, and they're mostly working on phones. We're not in person. It's a call center. And I think one of the next slides will actually have a phone number to call. So if someone is looking to go into residential level of care or stabilization, and we have 2 different levels of care for that, they're called 3.5 and 3.1. 3.1 is a little bit less intensity, so less hours of services in residential level of care. They should be calling our access if they have Medicaid, Healthy Michigan plan, and then if they don't, they can always give us a call to see if we have the ability to provide block grant funding, depending on many different things for eligibility. And if they also have maybe a third-party liability, is what we call it. That means Blue Cross Blue Shield, Priority Health, and Healthy Michigan Plan or Medicaid, they can give us a call. We're going to be the secondary payer, but we're going to try to refer that client to a provider that actually takes their insurance. That is a very interesting thing to navigate up here. Not many providers take those insurances. And if they only have third-party liability, so those other insurances, they may still meet criteria for block grant funding with that portion that their insurance does not cover. So they can still give us a call. Or if they simply don't know what they're supposed to do, they just know that they're looking for treatment, they can give us a call. And we'll see where we can, if nothing else, warm transfer the call for assistance. If they do not speak English, because most of the services are provided in English in our region, and that is the main language, we will be able to obtain quickly on the phone someone to interpret the conversation. So I just wanted to point that out. That is one of the challenges, but we have an agency that we can just plug into our call within minutes, and we'll be able to accommodate that. So screening is something that we quickly do within 10 minutes, let's say over the phone, to see if funding can be in place, current utilization, if clients are currently receiving any services, and where is it that we would be able to refer that client to. We have quite a network of residential providers and also OTPs, which is methadone clinics, that require these pre-screenings to be referred. Outpatient services do not require these screenings to be completed. Detox does not require these screenings to be completed. So let's say someone is seeking withdrawal management or detox in our region, they can simply call the provider. Now, if they don't know who to call, most definitely they can give us a call first. And we'll be able to assist from there, giving phone numbers, warm transferring, explaining the process, and so on. We would like to see those clients who are going into detox or withdrawal management to continue services, but we also understand that is not always possible due to having jobs, families, you name it, and just inability to maybe remain for a long period of time. At that point, we can also assist, whether that would be provider and withdrawal management or us providing some resources and information for outpatient services, intensive outpatient services, recovery coaching, and so on. We'll talk about that a little bit later. Another thing that Access is providing is care coordination. So what does that mean? And I've heard this before from you, Suzanne, specifically, is that it used to be a place that you would call and there would be only certain things that would be provided. It would be very brief, and this is all we can do. And we recognize that there was a lot more we could have done with clients, providing care coordination, follow-up calls, making sure that when someone is referred to a level of care, we give them a call within the next 3 days to make sure that they can make it. They have no issue with transportation. If they're looking to be referred elsewhere, if there's a sooner bed. So we try to give call to everyone we refer to, either residential or methadone services. Within 3 days, we try to reach out and just make sure that we're still connecting them to that service that we referred them a couple of days prior. We also, within Access, review all the ADTs. And so the question is, what are ADTs? When clients with Medicaid Healthy Michigan Plan are presenting in the emergency room for any reason, we're able to see that information. And if they're showing up for anything that is substance use related, or if that's just a part of their visit, we're going to run reports daily. Every morning we run those reports, see who presented in the emergency room, and then we try to follow up if we have an appropriate phone number and see what is needed. And that is something that is a very challenging task because we're just cold calling someone who may not want to talk to us, and we're just like, we know you were in the emergency room last night, but what is that actually doing? What is it meant to do? It is meant to connect someone to treatment that they may need, and they just didn't have resources, didn't have time, didn't think about that. They've been through a system quite a few times, and they were just not ready to do that again. So just providing support, resources, information, connection, and care to clients. So we do that daily, and we were not sure how that's going to work, but it's something that actually has incredible outcomes. So, and even if we do it for, one person a month and change how they're going to be in their recovery that day or that month or that year, I think that is a success. But we've had more success than one a month. So I think that it's really important to continue to spread the word, talk about what is it that we're trying to do. We can also provide information and resources. We often have parents call and ask questions. Now, we can't talk about the client specifically or child without a release of information. What we can do is we can provide information on who we are, what is it that we do, our services, resources. We can share information that I'm going to share with you on our provider network, all the contacts that we have, just how the process goes, and provide that support. And here you will see that we also have priority population follow-up. Priority population, we have designated from the HHS, our contract, and so on, who priority populations are. So everyone who belongs to that population, that would be pregnant IV using clients, and so on. We would be reaching out to them multiple times to make sure that we're following up with them, that they're receiving services that they need. And then next on the list is SCA, and I probably should have elaborated on that one and not just leave it like that, but those are single case agreements. And what does that mean? And we have a lot of these. That means the client is calling, they're from our region, from our 21 counties, they qualify for funding, but they're looking for a service that is not currently in our region. And it's due to conflict of some sort of conflicts. Let's say family members or friends are working in those that would have available beds, or there's something specific that other provider can provide and we cannot in our region. That is fairly rare, but it can happen. Or they're saying, it's actually closer to my house to travel to East Side OTP clinic, and I would really like to go there. I can travel with two of my friends or my sister, and I think I would really benefit from that. So for that east side specifically for OTP clinic, I think we have close to 20 single case agreements. So we're still able to provide services that are not necessarily in our region, in our network, and we just create a single case agreement. We also provide services with providers that are not in our region, but are in network. What does that mean? We have contracts with Great Lakes up in a UP for residential services. We have contracts mid-state, downstate for OTP, for outpatient, for residential, for withdrawal management, detox, and so on. So we're not solely based within our region. However, within our region, we have over 320, 330 residential beds. And that's a very, very, very high number of residential beds. So that is something that we can easily accommodate within the region if that is what his client is seeking. If they're looking for something a little bit different, maybe going to 1016 that is not in our region, we would be able to do that. I gave you a ton of information here and no one cut me off for questions, but if you have questions, go ahead, let me know. Any questions for now?
I've got one, and that is the phone number 24 hours? So can you be called anytime?
Yes, but referrals may not be provided 24 hours. Some referrals will be. So our phone number is 24 hours. However, NMRE access staff is able to do screening and referral 8:30 to 4:30. 8:30 a.m. to 4:30 p.m. Monday through Friday. Phone lines will be answered and clients will be able to speak with someone throughout the day, 24/7, but there may not be a very good way to screen them and refer them because protocol that is picking up calls for us does not have the ability to actually run insurance and eligibility. We're the only ones who can do that. We do call clients who call overnight and over holidays. We call them back and we try to link them with providers and resources the next morning. So every morning we come in, we run those ADTs, we run protocol reports, and then we reach out to all of those who call or present in the emergency room. Any other questions?
I'm wondering, is there an age restraint? I mean, as far as what age does it start? And the reason why I'm asking this is specifically yesterday, someone was asking about treatment for a 16-year-old.
Yeah. We would be able to accommodate that in outpatient setting or in residential setting. For adolescents, we have somewhat of a limited capacity. In region, we do not have a provider who is able to accommodate that. Most of our residential referrals are going up to the UP with Great Lakes, or they're going to Wedgwood. But screening can be completed with or without parents or guardians and so on, and for 16-year-olds. And we would be able to refer them if they're meeting medical necessity to residential. For outpatient, there's a different requirement for the assessment. So providers have to have staff that are trained. Most of our providers are able to accommodate that. But outpatient level of care is also available. It just depends on location and so on. Those are some of the challenges, but there's also a lot of ability to do it audio, video, and so on. So there's plenty of flexibility. We just need to be maybe informed at times that something is maybe urgent, that there might be a wait time for a different provider and so on. But yeah, we can definitely provide services to adolescents.
That's changed a lot because I know back when my son was young, he couldn't be diagnosed with a substance use disorder back around 20 years ago or so.
Yeah.
He didn't do it back then.
Things are changing, and I think one of the very, very important things is to address this early on. So we have to address it at the age of 16 if that is what is needed, so we can have different recovery path for that person. If we wait till they're 26, I think that the recovery path might be very different.
Yeah, the younger they choose to go into recovery, the better off they.
Yeah. Yeah.
That's-
So we have services, definitely have services available for treatment. We also have, as you know, all of you, I think, on a call, there is a lot of prevention funding that we provide, which is a very big emphasis that to provide prevention, information and services, because that is where we have to start. That's worth a lot more. But when we're talking about treatment, yes, that is definitely available if that's where we're at.
Thank you.
Mhm. We did try recently to provide a single case agreement for services downstate, and that was family choice. And I just want to point this out because sometimes we are willing to do, we're pretty much always willing to do single case agreements with the provider of choice. However, provider of choice was not willing to take or accept our contract at that time. So that was another challenge we had to navigate with the family. They found a provider, they were willing to attend, they've had experience with them before. We were willing to produce and actually produce single case agreement. They were not willing to accept due to capacity. So just there's a lot of pieces of that puzzle that we just have to be aware of.
Absolutely. Absolutely.
Any
other-
other questions? Okay. So this is our site where recipients can find information on what is it that we provide. And you will be able to find specific services for substance use diagnosis there. We'll talk about them a little bit more. Maybe if you have questions, we can talk about that. But when we refer to a specific level of care or where that's being requested to be authorized from provider, clients have to meet the medical necessity. And that is something that we have to focus on utilizing ASAM criteria, ASAM continuum at this time as an assessment or gain for adolescents. And for the authorization portion for Medicaid, we have to have medical necessity being met. Why is this important? Quite often we receive calls and there is a lot of frustration. They're saying, well, we really wanted this person to be in residential. At that time, they may not meet the criteria for residential, but we can put them in contact with the level of care that they're meeting criteria for. We had a lot of frustrated family members, frustrated courts, and so on, what they're saying, well, it is required for them to attend residential. And a client is saying on the other side, I haven't used in 3 years. I'm feeling good about my recovery. I'm doing everything I can. I really don't think I need to spend 40 to work on this 40 hours a week in a residential setting. I really want to keep my job. It's helping me with my recovery. My family's here. I really want to attend outpatient if that's possible. So there are going to be different sides to every story. What is required by a different system? What is it that can be funded by Medicaid, PHP, and so on? And what is it that client wants? And sometimes we can all agree the client should probably be in 3.5 residential level of care. It's something to stabilize the crisis. It's to help him go through that first couple of weeks, month, 2 months of starting the recovery, but client is not there yet. And in that case, we may suggest that although we think the best level of care might be higher, to start out with outpatient, start out with some services here and there, start looking into what would just treatment look like. And then if they're ready to go into higher level of care, then we would be able to go ahead with that. So these levels of care and services are always a big conversation to have with multiple parties, but we have to focus on a client and what they're willing and able to do and where is it that they're at. And we always have to take their safety into consideration. But NMRE is currently providing residential withdrawal management, MOUD, we're providing health homes, and we can talk about that additionally. What is a health home? What is care coordination? How does that look? We provide multiple levels of care for our outpatient. It's not just level of care 1. They're intensive. They're something that is called day treatment, partial hospitalization, provides a lot of services. And we'll talk about some specific services in a second. And I don't think I listed health homes anywhere in my presentation, most likely. So I just want to point out that NMRE currently has over 60 some locations in our 21 counties where clients can receive health home benefit. And so what is a health home? Is it a home? It is not. It is a model of care. And it is something that's been very important for our region. It is a care coordination administrative function that NMRE is reimbursing providers for to provide care coordination for clients and allow for better health outcomes for clients with all parties involved in clients' treatment. So let's say we have an opioid use disorder health home, alcohol use disorder health home that is funded through grants, and we have behavioral health health home. And so the name kind of suggests what is a diagnosis for someone to be enrolled. They'll have to have Medicaid or Healthy Michigan plan. And what happens is the client is showing up, and let's say we're just going to use a provider here. For example, they're showing up at OTP NEMSAS, and they're saying, I'm diagnosed with an opioid use disorder. I would like to be on this MOUD for my opioid use disorder. I also have a lot of health concerns. I have heart issue, and I have some educational needs. I do have some legal involvement that I'm working towards resolving, and I have some concerns with my children regaining custody. And I would really like some assistance with that. And so let's say NEMSAS has designated staff that would be able to review documentation, call on client's behalf, make sure the medication is the way it's supposed to be, talking to a client's doctor, reaching out to school, reaching out and communicating with parole or probation and so on, and working with CPS, for example, with that client or on client's behalf. And all of that through health home setting became a billable service for care coordination, which is allowing those settings to receive more reimbursement, supports, more funding, more staff, and for clients for those things to be taken care of and allow client to have better outcomes and easier recovery path. So it is something that's fairly robust in our region and very important to point out. We do run some outcomes that are based off of reporting on the backside and encounters. And so just to point some stuff out, we have very good follow-up metrics. So everyone who presents in the emergency room for mental health concern, we're tracking if their health homes followed up with them within 7 days and 30 days and so on. And some of our health homes are scoring in 80%, 90%, even 100% of follow-ups for certain measures. That tells us that clients that are enrolled into these programs are receiving very good follow-up care and coordination. So that is something that we're trying to expand throughout the region and make sure that we provide really good care to our clients. We also provide care coordination for health homes from PHP perspective. We open that up a little bit more with additional resources and some staffing. And so we can communicate. So let's say someone who's enrolled in a health home with appropriate release of information is calling us in crisis saying, I think I really need to go into residential today. What can you do to help me out? So we'll link them to residential. And then I have a team that will reach out to their health home and say, hey, Joe presented today, and he will be going to addiction treatment services for residential. Can you please reach out to him, make sure he has transportation, food, everything lined up, medication. And we just want to know where he's at so you don't discharge him. And you can call ATS and discuss his case and make sure that when he's stepping down, you can help him out. So we're just trying to have that flow of information and communication going. It is a very simple thing to do, but historically that's been very challenging. So we're now covering for that. So financially, there's a little bit of a boost, and then outcomes have been amazing. I just wanted to throw that out there because I think I forgot to add that to my presentation.
Can I ask some questions about that? That is so intriguing and definitely something I would like to learn about and understand a little better too. So some of the clientele that I work with are homeless, and but this sounds like maybe the same kind of thing that they could use in follow-up services and seeing that they're co-occurring, what they're presenting with co-occurring is being addressed, transportation, possibly placement. I mean, many times they're homeless and actually afraid to leave their known to go to something unknown.
Yep.
And if we actually had, like, this is new to me, if we actually had these things in place that we could do a soft handoff or do a care coordination plan with them, or face to face with them, and then how do we connect with your care coordination at NMRE and make it work for them?
I can send you a list of health homes. And again, those are just providers. They're not homes. They're just staffing in place to assist with this. Clients would obviously have to be enrolled. They would need some sort of a care plan and releases, but it is very streamlined. I can send you a list following this meeting, or to you, Suzanne, and then you can forward, of all of the health homes we have in place. They can also do outreach or you can help client, give them a call and go through a whole process, and then they would be able to provide care coordination for them depending on the need and what is documented. We currently have in region approximately 16 to 1700 of clients receiving this benefit. So it's a pretty good number. We would like to see that number increase because we know we have a lot more clients that would qualify, and that could be assisted. So I can provide those resources.
That's awesome. Thank you.
For example, CHS is one of the health homes. They have OHH and AHH. All 5 CMHs are behavioral health homes. For that, they would have to have mental health diagnosis. There's a code set that they have to follow. We have 12 opioid health homes within region, and some of them are OTPs. We have substance use providers, outpatient. We have providers who have most of the levels of care, or all the levels of care, like Harbor Hall Addiction Treatment Services. We have Bear River as one of the paneled ones. It is a pretty long list. We also have an OB provider as a health home provider, and she's able to also prescribe buprenorphine and take care of pregnant women, and which has been incredible. We have a primary care setting. We have multiple FQHCs that are health homes. So we're trying to diversify, and I'm sorry if anyone's listening and I forgot to mention them, but as I said, there's 60 some locations that are able to assist with this in our 21 counties. So it's pretty robust.
Great.
Some of the ways we're trying to help our clients. I kind of went completely sideways from what was on the screen, but that's okay. One of the things that we're really proud of, and we would like to see how this is going to work, a couple of months ago, NMRE said, hey, let's do something different. We're hearing a lot from providers saying, clients are showing up. We have a recovery coaches assist with things, and then we're not to that point of doing an assessment or treatment plan. We're just employing these recovery coaches to do amazing work, and we cannot get reimbursed for that. So we did a lot of research and work internally, and we decided to open this code up as a standalone service. It does require an admission in our Recon PC system, and does require needs assessment to be completed in diagnosis, which can be collected from prehistorical records and so on. But historically, this code, which is recovery coaching code, was provided only when someone had at least outpatient services. And now if someone is presenting with one of our providers saying, at this time, I'm only able to or willing to or open to recovery coaching, we would be able to reimburse for that. So that opens up access to services quite a bit. That opens up maybe flexibility, and it just allows clients to only receive this if this is where they're at. And it can also be a good step down. Someone is no longer in need of outpatient, so they don't need therapy at this time. They don't need case management, but they would like to continue recovery coaching. This is available, and we provide reimbursement for that. So we're kind of really excited about that. So if you have any questions about it, let us know. we would like to see it being used a little bit more than it is right now. It's been a couple of months. It's been busy, so we're just waiting to see how this is going to expand what providers are able to do and services and access that is given to clients.
Hey, this is Dave McGraham. I'm
Yes.
curious, do you have enough recovery coaches in the region for folks to access?
That is a pretty good question. I don't know. I think we have recovery coaches. I know that many of our providers have recovery coaches. But I think that would be a question because we're not keeping track of that capacity internally, as this was not a covered service in this fashion. It's been a covered service. There were some changes with MDHHS as to who and how can provide. So it is ever changing. It is not something that we keep close track of. So I wouldn't be able to tell you specifically how many therapists we have in region or recovery coaches. That ratio is something more so of a LARA and licensing jurisdiction. But I think this would be a good question for providers to say, do you think you have enough recovery coaches for the caseload that you have? And I'm pretty sure that the answer would be no, not really.
Thanks.
We know that some providers have more, some have less, that some are struggling to hire or struggling to keep. We would like this to be something that is sustainable and available to our clients, but that is up to providers as to how they would be able to staff and fund it. So if we can put you in contact with providers, I think that might be a better way to ask the question.
Thank you.
Yeah, and not some of the recovery coaching is more community-based, and we'll talk about that. And I think I have it as one of the slides. We do fund some of the community efforts through recovery coaching through PA2. So it's a different funding source. It's liquor tax. So it's not necessarily this typical funding that we were just talking about. The code that I was talking about is through Medicaid, Health in Michigan Plan, block grant funding, and so on. But we're trying to figure out how to expand availability of coverage for providers to be able to hire more. But there was last year at the end of PHE, we had a hiccup where MDHHS no longer allowed recovery coaches to provide audio and audio video services. There was a period of time when only requested it to be in person, so with the client in the same room. We did write to MDHHS, we complained, we requested expansion of that, and now it's allowed through audio and video together. So I think that was a small win, just to be able to meet clients where they're at, whatever that means. And we'll continue to advocate for that. We were not in support of only in person, especially in our region, when we have 21 counties and no transportation and so on. So there's some things that we have to work on the backside, but we also need more feedback maybe from providers to see if there's anything else we might be able to do to expand this. We're willing to listen to feedback, willing to work. We're open to hear more. So please keep us posted, let us know. And we'll see if we can help out. Another thing I wanted to talk about is recovery housing, and this is a pretty big one in our region. We have over 300 and some recovery housing beds in region that we know of, so probably 400. I don't know. I'm not sure. These are typically not funded through PHP. We have some that are funded through providers that they're contracted with, or providers have their recovery housing. What we pay when it comes to recovery housing is not all 318 or more. We have a couple providers that have that as part of the services they're providing, and then in that case, NMRE is able to reimburse for this. It is something that is available to our clients if they choose to utilize this, and there are some other efforts to assist with recovery housing. We have one that is funded through a grant. We also utilize some of the PA2 for recovery housing startups. So what does that mean? That we cannot remodel or build or buy, but we can maybe help furnish some of the recovery homes. So we've utilized funds for that. We're always limited to what funding is allowing us to do. So we have to take all the restrictions into consideration. But this is something that is a reimbursable service. And I think within last fiscal year, NMRE served 200 clients in recovery housing setting that we covered. If someone is presenting in recovery housing, we do require that they attend outpatient treatment on a regular basis, and we verify that through authorization process. Any questions on recovery housing? Yeah. And again, you can always reach out via email or call to Access or to me. Ooh, I skipped there one. But yeah, this is our phone number for Access, and you will see my email later. But when to call Access for questions, for suggestions, for any information that you may need, for if someone is in need of referral, if someone is in need of just information packet as to how things work, anything like that, you can always give us a call. Our staff will be answering 8:30 a.m. to 4:30 p.m. And we try not to have people on hold. We try to call people back. If we have to queue someone and call them back and they don't pick up, we'll call them again and then again, just to make sure that, because we had to put you in a queue, that we didn't miss your call. And we're trying to assist anyone calling. One very important thing is what I kind of touched on this earlier is confidentiality, that if someone is calling on client's behalf, if it's not a provider that we have established relationship with and releases of information in place to begin with for certain things, then we would require use of release of information. There's a link here. This is specifically the release information that we have to use. And it's not always the easiest one to navigate, but it's what we're required to utilize. So it is there. It's 5515. And if you Google that, just the PDF, I think you would be able to find it. But I'll share this with you later. So you can also click. It's a clickable link. This is also going to be a clickable link going directly to our site because it changes all the time. So I didn't just want to give you a copy of something that might be changing, but this link will take you to our provider directory with all the locations, levels of care, and so on. So it's something that is a pretty good resource, but you can also go to our site and look under provider directory. Any given time, you don't have to use this link. And there's a couple other things that I wanted to bring up is that, as I said earlier, we do provide funding for prevention. So not just for treatment, and we talked about mental health as well. We have funding for prevention. We have PA2 funding, which is liquor tax. And that is very much county-based, and we review that every other month. We have plenty of requests coming through for different things and different efforts. An initiative within our region to be funded that are typically not funded through other funding sources, such as Medicaid block grant funding and Healthy Michigan Plan. We have quite a few grants. We try to keep everyone informed of what the grants are, what they're for, and try to work with providers to make sure that you can utilize them and provide best possible care in region. We also have Women's Specialty Services. That's the WSS, because I just typed in the way I typically do and then provide explanation. This is not necessarily just for women. It is the name coming from MDHHS, but it's for parents pretty much. And providers will receive additional training and support to be able to assist those who are looking to regain custody, who are, taking care of children, having some issues with everyone remaining in a family and so on. So there are some additional efforts there and funding to assist families. And then, oh, I did put health home. Look at me. I was on top of it. And then again, health homes, which I think will be listed in that provider directory, but we have one that is maybe more detailed. So I would be able to provide that. And I thought I would maybe take half hour, but it looks like I was able to do a lot more. That's, I think, all I had for today. Now it's your turn.
Thanks so much. NMRE's come a long ways.
Thank you. Thank you. Yeah.
Definitely. Just the calls that we make up there when we need help is, I mean, it's a lot warmer than it used to be. And we appreciate that. We appreciate the changes that they've made.
Yeah, and I appreciate that feedback. You know, we're in it day to day. And sometimes we don't see those changes like that, but we know that the amount of work that it took to change certain things, to open it up a little bit, to just have more flexibility. And I think that was really important because, you know, working in this field, we ought to have that flexibility.
Yeah, it's definitely more accessible. I know like years ago, before you were even there, that
Mhm.
having someone that needed assistance, they didn't even want to call NMRE because of the way that they were treated.
Yeah.
But it's changed so much. And like I said, we really appreciate that, to be able to call and get that warm
Yeah. We
and
tried
help.
to staff it with this, you know, there was a purpose behind how we were organizing. So we wanted to be able to be welcoming, to be quick to respond, to be able to follow up, to have an idea of what all needs to be in place for someone to be taken care of. And that's typically not just one phone call. It takes a lot more. So we've reorganized internally to make sure we can accommodate that.
It's really appreciated. Does
Thank you.
anybody else have any questions? It's a lot of information.